Welcome to our video on pelvic organ prolapse. Let's get started. Here's our overview slide. Let's begin by discussing the definition. Pelvic organ prolapse is a common gynecological condition where there is an abnormal descent or herniation of pelvic organs such as the bladder, uterus, or rectum from their normal sites through the vagina. Here's a diagram showing the anatomy of the pelvis and the relationship of the pelvic organs to each other. Here is the uterus and the ligaments supporting it, the uterosacral and round ligaments. Anterior to the uterus, we can see the bladder, and posterior to the uterus is the rectum. Now let's discuss the pathophysiology. It occurs generally due to weakened pelvic support and increased intra-abdominal pressure. This leads to the herniation of organs into the vaginal vault. This herniation could be partial or complete. It's considered complete when the protruding organs extend beyond the vaginal opening. It's further classified according to the position of the prolapsed organ relative to the vagina. Herniation of the bladder is called a cystocele and causes a prolapse of the anterior wall of the vagina. Posterior wall herniation occurs due to herniation of the rectum, referred to as a rectocele, or the intestines, referred to as an enterocele. Herniation of the uterus or vaginal apex result in apical herniation. Apical prolapse is also often associated with enterocele. Herniation of all vaginal walls is referred to as uterine procedentia. Here's an image showing the various types of herniation. So a cystocele, a rectocele, and enterocele. All right, let's try a question. A 55-year-old woman presents to her primary care physician with a posterior vaginal bulge that increases in size with coughing and sneezing. What are the most likely herniated organs in this patient? All right, this is a 55-year-old patient with a posterior vaginal bulge that increases in size with coughing and sneezing. So she most likely has pelvic organ prolapse. A posterior vaginal wall prolapse can be due to a rectocele, which again refers to prolapse of the rectum. Or it could be due to an enterocele, which refers to prolapse of the intestines. All right, now let's move on to risk factors. There are multiple risk factors that can predispose women to pelvic organ prolapse. These fall into two main categories: weakened pelvic support and increased intra-abdominal pressure. Multiparity, vaginal birth, advanced age, and a history of pelvic surgery, for example a hysterectomy, can predispose women to prolapse of pelvic organs through weakened pelvic support, physical stretching, or trauma to the pelvic organs. Connective tissue disorders can also cause laxity of the ligaments that hold the major pelvic organs in place, thus weakening their support. Additionally, conditions that cause increased intra-abdominal pressure, such as obesity, constipation, or chronic cough, are also risk factors for pelvic organ prolapse. These can also exacerbate an already weakened pelvic floor. Okay, moving on to clinical features. Prolapse of a pelvic organ results in a sensation of pelvic pressure or fullness. Women may feel a protrusion or a bulge from the vagina that can be described as something falling out of the vagina. Loss of support of the anterior vaginal wall may affect bladder and/or urethral function, and it can also cause symptoms of urinary dysfunction. Patients may experience symptoms of stress urinary incontinence with urine leakage with coughing or sneezing. Patients may also have urinary retention due to obstructive uropathy as a result of the prolapse, as well as a sensation of incomplete bladder emptying. Loss of posterior wall support may cause defecation dysfunction, including constipation and fecal incontinence. Finally, women may also experience painful sexual intercourse or dyspareunia, as well as urinary tract infections due to ascending infections. Here's an image of a 71-year-old woman with uterine prolapse with the cervix visible in the vaginal orifice. Next, let's discuss the differential diagnosis. Here's a list of differential diagnoses that you need to keep in mind when suspecting a pelvic organ prolapse. This includes a prolapsed uterine leiomyoma, urethral diverticulum, and imperforate hymen. Let's briefly discuss prolapsed uterine leiomyoma first. A prolapsed uterine leiomyoma is a condition where an intracavitary leiomyoma is expelled or aborted by the uterus. As the leiomyoma descends through the cervix, it produces what is felt by the patient as labor-like pains due to the mechanical stretching of the cervix. Pelvic examinations will show a protruding round, smooth mass that's firm as well as a dilated cervix. Further physical examination will show an irregularly enlarged uterus, which is very suggestive of uterine leiomyomas. Patients may also have a history of heavy menstrual bleeding, which supports the diagnosis. Here's an image illustrating a pedunculated herniating leiomyoma in a patient with uterine leiomyomas. Notice the irregular contours of the uterus as a result of the leiomyomas. All right, let's try another question. A 29-year-old African-American woman presents to the emergency department with severe cramping lower abdominal pain. She has a history of chronic pelvic and back pain, as well as heavy menstrual bleeding. She says she is not currently sexually active. Pelvic exam reveals a firm, smooth, round mass in the vagina and a dilated cervix. A pregnancy test is negative. What would most likely be present on further examination in this patient? All right, this African-American patient with a history of chronic pelvic and back pain and a history of heavy menstrual bleeding most likely has uterine fibroids. Her current presentation with severe cramping lower abdominal pain and the presence of a firm, smooth, round mass in her vagina, as well as a dilated cervix, should raise suspicion of an aborting intracavitary leiomyoma. On further examination of this patient, the uterus will be irregularly enlarged, which is a characteristic finding in patients with uterine fibroids. So, in answer to the question, upon further examination of the patient, she'll most likely have an irregularly enlarged uterus. Okay, as we mentioned earlier, another potential differential diagnosis includes urethral diverticulum. As the name suggests, this is a herniation of the urethral mucosa that usually occurs in the mid to distal two-thirds of the urethra. It has similar risk factors to pelvic organ prolapse that we discussed earlier. Patients with a urethral diverticulum present with urinary symptoms, such as stress incontinence and post-void dribbling. Patients may also experience dysuria or painful voiding, as well as dyspareunia or painful sexual intercourse. Physical exam will reveal a tender anterior vaginal wall mass. This is a very characteristic exam finding of this condition that you need to remember for the boards. Patients with mild symptoms can be managed conservatively with observation and follow-up. Surgical diverticulectomy is indicated in patients with persistent symptoms or in patients with suspected malignancy. The last condition on our differential diagnosis is an imperforate hymen. An imperforate hymen is a congenital condition which occurs due to a hymen that is completely obstructing the vagina. It presents in adolescent females as primary amenorrhea. We discuss imperforate hymen in detail in our lecture on amenorrhea, so make sure to watch that video for more information. But briefly, patients with an imperforate hymen usually visit the physician due to delayed onset of menstruation and cyclical abdominal pain. Patients present well into their teenage years complaining that they have not had a menstrual cycle yet, when in fact they have been menstruating, but the blood has simply accumulated above the imperforate hymen and could not pass through the obstruction. This also explains the cyclical abdominal pain that these patients experience, which is due to their regular menstrual cycle that they're unaware of. On physical exam, this accumulation of blood presents as a blue-tinged bulb protruding from the vagina and is referred to as hematocolpos. All right, let's try another question. A 34-year-old woman comes to the physician due to urinary incontinence for the past 2 months. She reports small amounts of urine leakage after voiding. She denies urine leakage with coughing or sneezing. She has also been experiencing discomfort during sexual intercourse. Physical examination reveals a tender anterior vaginal wall mass that does not enlarge with the Valsalva maneuver. Post-void residual volume is increased. What is the most likely diagnosis of this patient's condition? All right, this patient is presenting with post-void dribbling, dyspareunia, and a tender anterior vaginal wall mass. So she most likely has a urethral diverticulum. Failure of the mass to enlarge with the Valsalva maneuver makes pelvic organ prolapse unlikely. Remember that post-void dribbling with an increased post-void residual volume is highly characteristic of a urethral diverticulum. All right, let's move on to the diagnosis. Pelvic organ prolapse is mostly a clinical diagnosis, a combination of a history of urinary, fecal, or sexual dysfunction, and a physical exam of a vaginal mass that increases in size with the Valsalva maneuver is diagnostic. The examination should be done while the patient lies on their back with their hips and knees flexed and thighs apart in the so-called lithotomy position. Then the patient is asked to perform the Valsalva maneuver, expiring against a closed glottis where the prolapsed organ would be observed. A digital rectal exam can also be performed to evaluate the tone of the anal sphincter, which may be decreased due to weak pelvic floor muscles. The degree of the prolapse can then be evaluated by assessing the level of descent of the prolapsed organ or organs. All right, let's wrap up by discussing management. The treatment of pelvic organ prolapse depends on whether the patient is symptomatic or asymptomatic. Asymptomatic patients only need reassurance and observation. Symptomatic patients who experience urinary, fecal incontinence, or sexual dysfunction can be treated conservatively or surgically. Conservative treatment consists of addressing the possible risk factors, strengthening the pelvic floor muscles, or using devices to provide pelvic support. Weight loss for overweight and obese patients is also indicated. A diet high in fiber helps decrease straining in patients with chronic constipation. Both interventions aim to decrease the intra-abdominal pressure. Pelvic floor exercises, specifically Kegel exercises, are indicated to strengthen the pelvic floor muscles. Vaginal pessaries can also be used. These are prosthetic devices that can be used to provide support for prolapsing organs. They are inserted into the vagina and can have different sizes and shapes. Resolution of prolapse along with bowel and bladder symptoms occur in the majority of the patients with pessary placement. Vaginal pessaries are also useful in patients who are chronically ill or in patients with contraindications to surgery. Surgical intervention is indicated for patients with no improvement of symptoms or who declined with conservative treatment. Anterior or posterior vaginal wall prolapse can be repaired with a surgical procedure called corporaphy, which aims to repair the affected vaginal wall. In apical prolapse, hysterectomy with vaginal apex suspension may be indicated. Suspending the vaginal apex occurs through attachments to the pelvic wall to provide support. The decision between conservative and surgical treatments depends on the patient's preferences and a surgical risk assessment. Here is an image of a corporaphy surgery for your reference. Here's a table that summarizes all of the conditions we discussed in this lecture. Feel free to utilize this as a quick way to review the high-yield points from this lecture. All right, let's finish up with one final question. A 50-year-old Gravida 5 Para 5 comes to the office due to involuntary urine leakage. She also reports a feeling of fullness in her pelvis. She has undergone a total abdominal hysterectomy due to severe dysmenorrhea caused by uterine fibroids. She does not smoke or drink alcohol. Pelvic examination shows an anterior vaginal bulge that increases in size with the Valsalva maneuver and some clear vaginal discharge. Which of the following is the most likely diagnosis? A. Neurogenic bladder. B. Cystocele. C. Atrophic vaginitis. D. Bartholin gland cyst. Or E. Enterocele. All right, this is a 50-year-old multigravid woman presenting with symptoms of urinary incontinence and an anterior bulge that increases in size with the Valsalva maneuver. So she most likely has a prolapsed pelvic organ, making the correct choice B, cystocele. Notice that this woman has several risk factors for pelvic organ prolapse, including age, multiparity, and a history of a hysterectomy. Recall that pelvic organ prolapse is classified according to the position of the prolapsed organ relative to the vagina. Herniation of the bladder is called a cystocele and causes a prolapse of the anterior wall of the vagina, which is what we saw in the patient in the vignette. Option A is incorrect because neurogenic bladder causes urinary incontinence due to a spinal cord or nerve injury, which is not present in this patient. Option C is incorrect as this patient does not complain of vaginal dryness or irritation, which are the characteristic findings of atrophic vaginitis. Option D is incorrect because a Bartholin gland cyst presents as a soft, painful mass at the vaginal vestibule that does not increase in size with the Valsalva maneuver. Finally, option E is incorrect because remember that enteroceles result in a posterior and not an anterior vaginal wall prolapse. So again, the correct answer is B, cystocele. And that concludes this section.